Hi guys, it's Professor Costa back with Advanced Central Perfusion Part 3. Okay, so if we have such severe heart failure and that the pump is completely failing, we have an ejection fraction of less than 25%, which means that the heart is unable to pump out at least 25% of what gets poured into the ventricle. So an LVEF of less than 25%, which is pretty yucky. And that means over 75% of the blood that gets poured into it from each cycle doesn't leave the heart, which is, why these patients are so symptomatic. All right, so we may need a cardiac transplant. It's the treatment of choice for those with dilated cardiomyopathy and end-stage heart disease. 2,300 patients a year in the US, and usually the criteria is the LVEF of less than 25%. And there's some things, we're going to have a separate lecture specifically about transplantation, because it isn't just like cut and paste where we take the heart out of someone else and put it into you and all set, like a new battery. That's not how this works. There's a lot of rules, a lot of self-care, a lot of ability to understand and be able to take care of the new heart. It is a huge responsibility. All right, so you have to have a life expectancy of less than 1 year. All right, you have to be at death's door, basically. We prefer you to be less than age 65. All right, there's all types of transplantation classes, right? Things that we would, err on the side of not letting you have the heart would be, if you have cancer, that's advanced stage. If you have active infections that aren't being treated, if you have other end-stage organ failure, so if you also need a liver transplant and a new kidney, the fact is that even with a new heart, you're unlikely to survive that. So if you're addicted to alcohol or have an active drug abuse issue, you have to have a stable psychosocial profile. So if you're bipolar or schizophrenic, you have to be stable and on medications and in therapy. So if you're not a good candidate otherwise, if you have severe diseases in any other category and you need a new heart, you may not get the new heart. That's the point I'm trying to make. We're trying to save someone that has a above average chance of surviving with the new heart, right? You also have to be about the same size. You can't take a heart, I'm going to use my Game of Thrones reference from the little Khaleesi and put it into, the first hubby there called Drogo. You can't put, a heart from a 4-foot tall person into a 7-foot tall person. They got to be about the same size, and they have to have ABO compatibility, right? And we'll go over more on like the cellular part of this when we have our transplant lecture later on in the term. Okay, but right now we're just talking about the heart, like the actual pump. So the transplanted heart, when we cut and paste, not to put that in glib terms, remember that we're severing the nerves that were connected to the donor's heart. And because you can't just stitch a nerve back together and have it work. Once the nerve is, severed, it's now not going to be responsive to the central nervous system, which is how before we, cut the heart out and paste in a new one, if I'm excited, my nervous system tells my heart to speed up. And if I'm going to go to sleep, things slow down. Well, that's not going to happen with a transplanted heart. It's unresponsive to vagal stimulation. All right, so they may need some things like isoprel to maintain their blood pressure, atropine, beta blockers, DIG. Carotid sinus pressure is not used, okay? So we may need to do some things differently than we would in a person who hasn't had a cardiac transplant. That's what I'm trying to say. Drugs that would affect the nervous system, which then affects the heart, aren't going to be used because those receptors aren't going to be receptive. They're not going to do their job. So we're going to use different medications. A new transplant may cause hypotension in the immediate post-op phase. Why? Because the rate of the heart's beating, it's going to go to its own intrinsic rate, which is a little bit lower, and it's not going to speed up the way that it would in a innervated heart. Okay. We want to prevent rejection, and these are on the slide just for reference, cyclosporin and Imuran. That is material for another lecture. So we are going to go over all the cellular parts of transplantation and the myriad of medications. So it's just on here for example, but you're not being tested on the specific rejection medications at this time. All right. I do want you to realize that if we've taken someone else's heart and put it into our patient, that they will have they could have signs of acute rejection, or just an angry heart that's kind of upset from being mishandled and placed in another person, which could include dysrhythmias, hypotension, weakness, fatigue, and dizziness. Okay. Signs of acute rejection would be signs of acute heart failure, which are all of those, right? So we can check a biopsy if we suspect that rejection is occurring, and that's where we're checking at the cellular level if there's cells attacking the new heart. So a thoracic aortic dissection is acute and life-threatening, and it has a huge mortality rate. Poor John Ritter. I don't know if you're older like me and you watch Three's Company, or if you watch the 8 Simple Rules, the dad from that show. He died from an aortic dissection, and it pretty, if they don't catch it early enough, you will die. It's a tear in the intimal lining, sorry. So, the endothelium of that great vessel, the aorta, it has layers to it, just like every part of our body. And what happens is that there's a tear and blood kind of pools underneath one of the layers. It creates a false lumen, meaning a dead end in the highway system that is your blood supply. So as the heart contracts, each systolic pulsation increases pressure on the damaged area, and it weakens, right? And it causes a bigger and bigger tear and a bigger dead end. And it can actually cause a roadblock. It can occlude major branches of the aorta, which would cut off blood supply. Think of everything that your aorta feeds, which is everything. So it can cut off blood supply to the brain, abdominal organs, kidneys, spinal cord, and extremities. So you'll see, if you look at the arrows, you'll see the dead end that gets created. There's a little tear in one of the layers of the aorta, and what happens is that blood gets pumped in there. So clinical manifestations, this is where it's kind of insidious. Oftentimes, patients have experienced chest pain, but they think they're having a heart attack. And in fact, many times they present, and that's the initial presentation at the emergency department. It can also be sudden severe pain, right, in the anterior front part of the chest, right? And it can have pain that goes down to the spine, to the abdomen or legs, all right? Some patients report a feeling of tearing or ripping. Some people just have stomach upset. They feel like they have the stomach flu. Also remember that not everybody presents the same for the same disorders. If you have a patient with diabetes, for instance, they may only have the GI upset. A lot of the innervation in the chest wall, diabetes does damage nerve impulses, and they may not have the pain, okay? Cardiovascular, neurologic, and respiratory signs may be present. Everyone reacts differently to this. The classic description that you may see in a testing situation would be that sudden severe pain in the front part of the chest, or the tearing or ripping pain. A lot of times, though, this looks like a heart attack. And in the case of John Ritter, they didn't realize it. He wasn't feeling well. He felt tired, and I think in reports he said he had some stomach discomfort. And he waited throughout the day and didn't present until late. And he actually succumbed to this disorder. So just to put it in perspective of someone even someone who has access to excellent health care can have a poor outcome if they don't present early enough. So you'll see our normal wall of our aorta, and then you'll see that tear in the dead end, the tear in the lighting. And depending on where it occurs in the aorta, really, can change how the symptoms present. Okay. So some complications of aortic dissection include cardiac tamponade, and that's when blood from this dissection leaks into the pericardial sac. Now this is bad. Our pericardial sac isn't supposed to have extra fluid in it, just enough to lubricate and let the heart move with ease of movement. We want our heart to be able to move the way it needs to. Remember, when blood sits around anywhere, it clots. And so we can actually, and if you get too much blood in here, it compresses the heart and limits its ability to function and pump, okay? If we have a rupture, an aortic rupture, that means that the largest artery in your body has broken open, so that's going to result in exsanguination and death. Exsanguination is when you bleed out, right? So the patient will start pumping instead of throughout the body. The blood will go into the chest cavity and the patient will bleed out. Okay, so our dissecting the thoracic aortic aneurysm, you'll see the tear in our dead end, and you can see that's going to occur where it occurs in the chest wall. So some patients may complain of back pain as well. So how do we fix this? So if we haven't ruptured, we want to make sure that our blood pressure is managed, right? We don't want a super high blood pressure that could increase our risk of aortic rupture. So ideally a beta blocker, right? A calcium channel blocker, maybe some nipride or an ACE inhibitor. So we want to manage the blood pressure. Surgical intervention. So having a section of the aorta resected, we're going to cut that bad section out and replace with a synthetic graft material, or we could do endovascular grafts. So we may be able to take a graft of an actual section of blood, a blood vessel, and implant it there. Okay. Postoperative care, well, you've just had surgery on the major artery in your body, so they're going to be in the ICU. And we're going to have to watch for signs of worse, that this could, leak. Patients can have some CHF. Anytime we have general anesthesia, a patient is at risk. So we're going to do the whole shebang. We're going to keep really, really close eye on this patient and make sure that the graft isn't leaking or that the patient isn't going into signs of CHF. So if we have a patient that we've done surgical intervention on their aorta or their heart or their lungs, anywhere in the chest cavity, that patient is most likely going to have a chest tube. And we have to know how to take care of that as a nurse. So a few basics, and every situation and every patient is different, but generally speaking, we want to keep the drainage system 2 to 3 feet below the patient's chest. We want to keep the tubing patent, so we don't want it kinked off or a big block. We don't want the patient's chair to be sitting on it. We want to look for those dependent loops because it is soft tubing. It's a very soft kind of hose, and we don't want it curling up on itself. And remember, even blood in a tube, if it sits around, is going to clot. So we want to make sure that those tubes stay patent. We want to watch and record the amount of drainage. So there are certain procedures where you just it's dependent on how soon it is after the procedure, what type of procedure, what the provider is expecting. That's why I'm saying everything's different. If we're putting in a chest tube for a pneumothorax, we're expecting mostly air. If we're putting in a chest tube for an empyema, which is an infection in the lungs, we would expect nasty drainage and some blood. If we're putting a chest tube in for an intrathoracic bleed that we've repaired, everything is different. But we don't want changes, right? So if there's a huge increase or decrease in the amount of drainage or what color it is, or it switches from clear to bloody to, we need to let our provider know, okay? If we have to have a bottle of sterile water, you know, the little bottles available, and that's in case that something happens to the system and it gets dislodged from the collection device. What we want is we want to maintain water suction, so water, because we don't want the tube open to air. What's going to happen is if that tube is just, you know, cut or damaged or pulls out of the collection device, and now you have just a tube connected to your lung that's open to the air, your body is going to suck that air in, and we're going to end up with a gigantic pneumothorax. So we do not want that to happen. So if it becomes dislodged, we just dunk it in water, the sterile water, and it keeps the air from coming in, and it also allows for air to escape. That's the beautiful thing about a chest tube. And we want to maintain the occlusive dressing. I've had different cardiothoracic surgeons with very strict and specific ways they want their dressing done. So some want it completely, you know, like tied till the cows come home with all types of tape, and others want to be able to come in and peek at it whenever they want. I've had surgeons come in and give the entire ICU staff a training on their preferences. So, but in general, we want to maintain an occlusive dressing. One, so that it stays clean, and two, for that air effect. We don't want air to rush into that space. Okay, so this is our chest tube setup. And in the oldie-timey days, before they started manufacturing these regular kits like the Atrium, they used bottles. And in fact, a friend of mine about 15 years ago moved to Texas and started working in a cardiothoracic ICU, and they were still using the bottle system. So the premise is the same. So we have the suction chamber, that's A, and that's where we prescribe the centimeters of water. It's literally regulated, the amount of suction is regulated by how deep the water is. So the usual setting is 20 centimeters, but your surgeon may, prescribe something different. So we're going to connect that. It's either going to be to suction or it's not going to be to suction, but usually it's set to suction. But don't worry, the bubbling, how fast it bubbles or how slow it bubbles is set by the wall, but the actual amount of suction that's going to the patient is by the level of the water. Okay, so the depth of water sets the vacuum pressure, not how vigorously it's bubbling because you cranked it up on the suction device on the wall. Okay, though the faster it bubbles, the more likely that it's we're going to have evaporation occur. So you want a nice gentle bubbling. Okay. Then we have the middle container, which is C, and that's our air seal. So the water seal. So that's going to help prevent any air leaking into the patient, right? So this is why we can't have that bottle of water next to the patient's bedside, the sterile water, in case it becomes dislodged, and we would just replicate the water seal by placing it in water, all right? So that prevents air, it allows air to escape, but it also, prevents air from rushing into the patient. And then D would be the collection drainage from the patient. So we're going to be watching that like a hawk, making sure that it hasn't changed consistency or color or start to smell, or the output changes significantly, either an increase or a decrease. There are wet systems and dry systems. So for A, the A bottle, and you look at the Atrium there, that's from the 2002 single collection, that's also using a wet system. You can see the water, there's actually a little pellet in there so that the water changes to a blue color so you can actually see it. In some newer systems, they have the dry system. So it's still to suction, but it's set up with a special billow so that you can see it occurring, but it doesn't actually, you don't have to pour water into that spot. Where you still do pour water is in the water seal. Remember, the water seal is important and it prevents that pneumothorax from occurring. And that, if you look on the atrium system, that's the lower, you can see just a little bit of water in there, and that prevents the air from rushing into the lung. Okay. And also on the atrium system, they have some extra bells and whistles like little pressure gauges and so forth. D, if you look on the atrium system, you can see that this system allows for 2,000 milliliters of drainage. These are a single-use item. We don't, pop these off and then put them on another patient. And you might be wondering how we record intake and output. Many facilities have their own policies and procedures on this. Most rely on things like tape and a marker, or simply documenting specifically what number you started on your shift and what number you ended on your shift, and then the output is recorded by, subtracting the amount. I've worked in places where we just used a marker or we used tape. It's really important, though, in your handoff report, that you note where the drainage was, the consistency, how much occurred during your shift, whether or not you needed to do any type of intervention on the chest tube itself, if you've noted any type of air leak. Occasional bubbles are normal in the C bottle. Okay, occasional bubbles. If it's continuously bubbling, then that may mean that there's a leak in the system and that you should report that to the provider.